Yes.
So basically, I'll be discussing these three terms and hoping to make them not as unfamiliar as they might appear in the first go. So this is a representative case of a middle-aged female who had decreased vision in her right eye to 624. Clinically, it looks like choroidal neovascular membrane, and OCT confirms that it's a type 2 CNVM with intraretinal fluid and some exudation as well, some subretinal fluid also. And here is the membrane, which with the flow that you can see on Octa. Now, this is the angiography. And here you see a predominantly classic type of membrane. So this patient was advised anti-VEGF injections, and you can see after the first injection how the membrane is regressing and the fluid is decreasing. Now this is after the 3 injections when the BCVA improved to 6/12. And here you can see there is no fluid, but there is a hyporeflective space here along with a dip in this layer. So this is the membrane again contracting on OCT. So this is what is known as focal choroidal excavation, an unusual concavity in the choroid detected by the OCT, which occurs without a posterior staphyloma or scleral ectasia. And when it occurs in isolation, it is characterized by good visual acuity and a normal overlying retina. So it's common in the 4th to 5th decade, no sex predilection, and is unilateral and non-progressive. These are the cases which have only FCE. But however, more often it is picked up in the presence of a concomitant or unrelated disease, which may be central serous chorioretinopathy, polypoidal choroidal vasculopathy, any type of CNVM. And these are the cause of the visual symptom that lead to the detection of a FCE on OCT. Now, this term was first described by Lee Jampol in Retina in a Diagnostic and Therapeutic Challenge in 2006. And then it was after about 4 years that further classification of this was given into the was given at ACTA. And Margulis published a landmark paper in 2011 in Archives where he termed this as a FCE or a focal choroidal excavation. So since then, the number of articles on this has increased to around about 20 in 2014 to about 130 now in 2021. So FCE are classified into 2. One is confirming FCE when there is no separation and there is preservation of the EZ and RP. And these are the non-confirming where there is a separation of the photoreceptor tips from the underlying RP. And here you get a hyporeflective space, which sometimes might have hyporeflective material, and it may represent SRF with shed outer segment debris or inflammatory material. Now, deeper lesions tend to be wider, and it has been shown that abnormal hyperreflective choroidal tissue can be present in about 50% cases, which may represent scarring. Now, 3 morphological patterns have been described: the cone-shaped, the bowl-shaped, or the mixed type, in addition to confirming and non-confirming. So here are some clinical examples of FCE. This was a middle-aged male with epitheliopathy owing to CSC in both eyes. And here you can see a FCE, which is non-confirming in the right eye and a bowl type in the left eye. Now, they are commonly associated with Best vitelliform macular dystrophy. In fact, that's the commonest dystrophy which shows FCE. And here you can see it is bilateral. And there has been a hypothesis in a paper by Dr. Vinod himself that it's actually related to the occurrence of the fibrotic pillar. Now, this was another patient. He had autosomal recessive bestrophinopathy, where you can see some skytic cavities and here a FCE in the right eye. So this was another interesting case of Stratsma syndrome with MNF, myopia, amblyopia, presented with the macular hole RD, and after surgery was found to have a FCE beneath the closed macular hole. So the current classification which has been proposed is etiology-based into congenital or primary, which are the unilateral stationary lesions, or the acquired secondary, which are associated with some other ocular disease, like we have seen pachychoroid disorders, choroidal neovascularization, inflammation, dystrophies, and sometimes choroidal osteomas in the process of deossification. Now, the pathogenesis, several hypotheses have been put forward. In inflammation, it is said that if additions form between the photoreceptors and choroid, it gives rise to a conforming FCE. Whereas if there's mild inflammation or early resolution, it will produce a non-conforming FCE, basically because there is loss of structural integrity of the RPE and basement membrane, causing an outward bulge of the RP. So, as I said, in BEST, there is, questionable role of the fibrotic pillars or vitelliform deposits. And in pachychoroid, in which it is most commonly associated, we still do not know the reason for thicker choroids to have a FCE. So it's important to differentiate this from other disorders which have focal choroidal thinning, which, like in this case, which is a post-traumatic choroidal rupture, a choroidal vascular disorder, or some infection. And of course, staphylomas has to be ruled out. So the take-home messages about this entity are that it can be picked up as an incidental finding in asymptomatic eyes, but you must carefully examine the eye and the OCT to rule out CSC, CNVM, PCV, inflammation, and dystrophies. Now, presence of an associated FCE does not alter the prognosis or treatment, and we are yet to understand the clinical significance of this entity. Now, coming to the next case, this was an elderly female with decreased vision in her left eye. She was a myope to 6/18. Here you can see some RP atrophy and some autofluorescence changes. So FFN ICG showed stippled hyperfluorescence and hypersenescence. And here is the OCT. So a vertical scan shows subretinal fluid with some elongation of the photoreceptor outer segment tips. And you're tempted to make a diagnosis of a central serous chorioretinopathy. But look what happens on the horizontal scan. Here we have what is known as the dome-shaped macula with subretinal fluid, and this is not a CSC. So Octa confirmed absence of neovascularization. This is the other eye of the patient, which was normal. Now, dome-shaped macula or dome-shaped maculopathy is an inward deviation of the macula with respect to the chorioretinal concavity, by definition more than 50 microns on OCT, seen in patients with high myopia. But it has also later been described in eyes with emetropia and hypermetropia or without a staphylogram. The risk factors are an older age and a longer axial length. Now, again, this was first described somewhere in 2008 by Gosher et al. And then there was renewed interest in 2011 to 14, but really picked up after that and today there are more than 150 publications on this entity. Now, the dome can be horizontal, vertical, or a round dome. So a horizontal will only be picked up on a vertical scan. A vertical will be picked up only on a horizontal scan, and a round will be picked up on both scans. So it is important to do both a horizontal and vertical scan of a sufficient length to pick up a DSM. For example, this one will be missed on a horizontal scan, this will be missed on a vertical scan, and if you have a scan of insufficient length, it will miss a round dose. So again, I want to reinforce, you must do at least one horizontal and one vertical scan of sufficient length to detect DSM, especially in myopes where you suspect this. For example, this female, you see the horizontal scan is normal, but look at the vertical scan. Another female, a myope, the vertical scan is normal, but here you pick up the dome on the horizontal scan. Now, the pathogenesis, again, is controversial. It may be scleral introversion, which is resisting the development of staphyloma. Sometimes you see underlying scleral thickening in these cases. It can also be localized variation in the thickness of the sclera. Choroidal thickness changes have been found in some, but not consistently, so it cannot be the pathogenesis in all of them. And what is now accepted is that there are macular basement membrane defects, which lead to a focal relaxation of the posterior staphyloma and this bowing. So the height of the bulge increases with time as a result of the deepening of the surrounding staphyloma. This is not accompanied by a hypermetropic shift. What is the clinical significance of DSM? It does not affect visual acuity by itself unless there is a associated SRF, like we saw in the case of flat irregular PDs and SRF. This is the most common finding associated with DSM. It resolves over time in more than half the patients with resultant RP atrophy. Now, risk factors are a vertical dome, a bulge more than 250 microns, and a greater choroidal thickness. The pathogenesis and the fluctuations are similar to CSC, and treatment is indicated only if there's persistent fluid with visual decline. The same modalities are used as CSC, but the results are still inconclusive. Now, the associated myopia can also cause a CNV, a type 2 most commonly in association with the DSM. And finally, you can get lamellar holes or ERM or even full thickness macular holes. What's the upside of this dome? It has been found to levy a protective effect. So there is less foveal schisis and more extrafoveal schisis, where this dome kind of acts like a macular buckle. Here you can see this area has no schisis at the top of the dome. Now look at this patient. This is a young myope, and these are his scans. This is the vertical scan of the left eye and this of the right eye with some subretinal hyperreflective material, most probably a CNVM. Is this a dome-shaped macula? No, this is what is known as tilted disc syndrome and is a common differential of the DSM. Now, unlike DSM, it is associated with moderate or low myopia, myopic astigmatism. The inferior fundus is tessellated as opposed to the posterior. There you'll find the infranasal tilted disc, infranasal crescent or conus, and situs inversus of the retinal vessels. Since it's an inferior cephaloma, you'll only see that eccentric dome on a vertical scan. So here you'll understand if you see both of them. Here it's only on the vertical scan and the shape is different from a DSM. You can also sometimes confuse it with a choroidal mass lesion such as a choroidal hemangioma, but a clinical corroboration will make this diagnosis easy. So here you see the shape of the dome is similar, but here you have a hyporeflective space in the choroid when it's a hemangioma. So what are the take-home messages about this entity? It's pretty common in high myopes with longer AL, and you'll find it if you look for it. How do you look for it? Careful OCT scanning with a horizontal and vertical scan of sufficient length. Now, most commonly associated with SRF without CNV, which causes visual decline, and these cases can be misdiagnosed as CSC. So you must also differentiate a dome from a tilted disc syndrome when you come across one. Now, the last entity coming to peripapillary intrachoroidal cavitation. Now, this is basically an asymptomatic localized orange elevation of the RP in retina, usually seen at the inferior border of the myopic conus. Now, the vein is markedly bent at the border edge. OCT shows an intracroidal hyporeflective space beneath the normal RPE plane. Here you can see this is the original paper where it was described. And it's important to recognize this because these are stable lesions which don't affect the visual acuity, but they may result in visual field defects, and you should not misdiagnose it as a glaucoma, as retinoschisis, as a peripapillary CNVM, or a hemangioma, or a granuloma. Now, here you see 3 types have now been described based on EDI. You can just have a peripapillary choroidal cavitation, or you can have it associated with a thickening. So to conclude, these 3 new terms, Fce, DSM, and PCC, they are diagnoses that can only be made on OCT. About Fce, remember that it doesn't alter the prognosis unless associated with another ocular disease. DSM should be looked for and ruled out in high myopes, and be careful whenever you see a CSC with high myopia, look for a dome. Tilted disc syndrome should also be looked for in these cases, which is a common differential. PCC is a stable lesion and should not be misinterpreted or treated as a glaucoma or a choroidal mass. Thank you all for your patient hearing. And with this, we come to the end of the talks.